Now we'll talk about some ligament injuries. The Fuchs mechanism that we talked about earlier can also cause a tear of the scapholunate ligament. If these injuries aren't diagnosed and treated, they can progress to some severe complications, like DC, DISI deformity, which stands for dorsal intercalated segmental instability, and that can progress to a slack wrist, which stands for scapholunate advanced collapse, and is an advanced form of arthritis. If there's any concern about this injury, then it's best to refer to a hand surgeon. In this case, the location of pain and swelling is at the dorsal radial wrist, distal to Lister's tubercle, which is a prominence on the dorsum of the distal radius. There's usually pain on extension and radial deviation. A positive Watson test indicates instability, but athletes with acute injuries might be in too much pain and you may not be able to do it. You should get regular x-ray views, but they might be negative, so it's important to include a clenched fist view or grip stress view like in this picture, ideally bilateral for comparison. A gap larger than 3 millimeters between the scaphoid and lunate is abnormal, and that's circled here. This is called the Terry Thomas or David Letterman sign because it looks like a gap between teeth. Can you see the similarity? X-rays might be normal in partial tears, and MRI is more sensitive, but arthroscopy is actually the gold standard for diagnosis. These are the steps in the Watson test to check for scapholunate instability. Start by placing your thumb on the palmar aspect of the scaphoid and apply dorsal pressure. Keep that pressure while you move the wrist from ulnar to radial deviation. A painful click is a positive test. Lunotriquetral injuries are less common than scapholunate injuries, but they also occur with a Fuchs, or a sudden axial load while the wrist is extended and in radial deviation. In this case, the pain is more ulnar than in scapholunate injury, and athletes often complain of weakness, giving way, and clicking with loading. The picture shows the lunotriquetral shear test, which is done by pushing dorsally on the lunate and on the palmar aspect of the triquetrum. A painful click is diagnostic. X-rays are usually normal, and MRI might be helpful, but arthroscopy is the gold standard for diagnosis in this injury as well. Lunotriquetral injuries are different from scapholunate injuries since they don't lead to progressive arthritis. They usually heal well with immobilization, but if symptoms are ongoing, then surgery is an option. Lunate and perilunate dislocation aren't seen as commonly in sport medicine because they're associated with high energy trauma. But when they do occur, they're frequently missed, and they need urgent surgical treatment to prevent long-term instability, avascular necrosis, degenerative changes, and nerve compromise. The mechanism is impact with the wrist in extension and ulnar deviation, and you should suspect it in contact sport athletes with wrist swelling and decreased range of motion. The carpal tunnel can be compressed, so it's especially important to check neurovascular status and function of the median nerve. Athletes will have severe pain, swelling, and deformity of the wrist. If the median nerve is compressed, then they may have paresthesias in the first 3 fingers and the medial aspect of the 4th finger. The diagnosis of lunate and perilunate dislocation is made on X-ray. You might need a CT to look for occult fractures or for surgical planning. Before we look at the abnormal pictures, here's a normal AP and lateral wrist X-ray to review. Note the alignment of the scaphoid in green, the lunate in yellow, and the capitate in blue. None of these are overlapping. On the lateral X-ray, the radius in red, the lunate in yellow, and the capitate in blue are all in a straight line with the capitate directly over the lunate and the lunate directly over the radius. So if we draw a vertical line like this, it will intersect all of them. Here are X-rays showing a lunate dislocation. On the left, in the AP view, the lunate, which is outlined in blue, looks triangular like a piece of pie and overlaps with the capitate above it. There's also a little ulnar styloid fracture here, but that's a secondary injury. Let's compare that to the normal wrist X-ray, where the lunate is not overlapping any of the other carpals. On the lateral view on the right, the lunate is outlined in yellow and is anteriorly dislocated. It looks like a spilled cup of tea. We can't see the median nerve in this picture, but that's exactly where it would be, so you can see why it would get compressed. The radius, which is outlined in red, and the capitate, which is outlined in blue, are still in the correct alignment. Here's the normal lateral wrist x-ray for comparison. This is a lateral x-ray of a perilunate dislocation, which can be easy to miss. The lunate is outlined in yellow, and it's in the normal position over the radius in green. The capitate in blue should be directly above the lunate, but here it's dislocated dorsally, as indicated by the red arrow. Here's the normal lateral x-ray again for comparison. Remember, if you draw a line through the center of the radius in the lunate, it should also intersect the capitate. Both lunate and perilunate dislocations require urgent surgical referral so they don't develop any of the complications of avascular necrosis, long-term instability, or permanent nerve injury. Distal radioulnar joint injuries can be acute from a fall or chronic from repetitive pronation, especially if there's a concurrent TFCC injury, since the TFCC is an important stabilizer of the distal radioulnar joint. On exam, there will be focal tenderness and possibly swelling between the distal radius and ulna. There may be decreased pronation and supination range of motion, and increased movement on the piano key test when you grasp the ulna and try to move it in a dorsal and volar direction relative to the radius. There may also be a painful click with this test, or with pronation and supination. X-ray might show widening of the joint space on the AP view, as shown in this picture, and you might see dorsal subluxation of the ulna on the lateral view. If X-rays are negative, then CT is more sensitive. Reduction in splinting might be adequate for treatment, but if it's highly unstable, or if there's an associated TFCC injury that might need repair, then they should be referred to a surgeon. Injuries to the TFCC can also be acute from a fall and can be associated with distal radius or ulna injuries, or they can be chronic. Chronic injuries are common in gymnasts, contact sports, or with any activity involving loading and repetitive ulnar deviation or wrist rotation. Pain is localized to the ulnar aspect of the wrist, at the fovea, or the soft spot just distal to the ulnar styloid, and it's worse with any loading or ulnar deviation. The press test, which you can do in clinic, involves asking the athlete to use both hands to push up from a chair from a seated position. This reproduces axial load, and it's positive if it reproduces the pain. X-rays might show positive ulnar variance, which predisposes to TFCC injuries because of the increased compression forces. MRI or MR arthrogram is more sensitive, but sometimes it's negative. Acute injuries could heal with immobilization, especially in younger athletes. Chronic injuries may respond to bracing and strengthening. If pain is ongoing, or if there's instability of the distal radioulnar joint, or if there's positive ulnar variance, then surgery might be needed.